like in New York City. I'm 1,000 miles away, but girl, tonight you look so pretty. Yes, you do. Times Square can shine as bright as you. I swear it's true. Hey there, Delilah, don't you worry about the distance. I'm right there for you, lonely. Give this song another listen. Close your eyes. Listen to my voice, it's my sky. I'm by your side. Oh, it's what you do to me. It's what you do. Oh, what you do to me.
All right, hello everybody. Good afternoon. I'm guessing everybody can hear me okay since you've been listening to elevator music for 30 minutes. My name's Rachel. I think I have spoken to most of you on the phone via text or email. Thank you so much for joining today. We have a few housekeeping things I'm going to go through real quick, and then we'll hand it over to Dr. Tseng to get started. A lot of you have asked how long should you expect to be on. I am guessing right at an hour. So just welcome. Again, this is our virtual education event, patient event. I am one of the patient educators in Hampton Roads that works with Dr. Tseng. A lot of you have asked, what do I do? So you'll learn about that a little bit more. First of all, some of you I know are calling in over the phone. That's fine. You won't be able to see the screen as you hear Dr. Tseng speak to it. That's okay. You can always follow up with me with questions later. You are going to be automatically muted. Everybody for patient privacy is muted, and we cannot see your screen, nor can we see anyone's names. If you have questions afterwards, feel free to call, email, text me. Another thing you will see, let me flip this here. That is me, Rachel. My cell phone number, in case you can't see the screen, it is 757-506-5170. And then my email, which I think everybody has if you've registered. Again, feel free to send me questions or follow up to either that, call, text, or email. You also have my information in your confirmation email that you got when you registered. So Dr. Tseng's going to speak in just a minute, and then at the end, we are actually lucky enough today to have a patient ambassador on the call. Mr. Clark Brown is a volunteer patient who has offered to share his personal chronic pain experience. He is not paid by Boston Scientific. He is truly volunteering his time. He is also a former patient of Dr. Tseng. He has a fun story he'll share with you. And we just thank you so much, Mr. Brown, for joining us today. So now I'm going to pass it over to Dr. Victor Tseng, who is an interventional pain specialist here in Chesapeake, Virginia, with Sports Medicine Orthopedic Center. He can take it away. Let me just get some of these slides out here. You got it.
All right. Afternoon, everyone. Thank you, Rachel, and thank you, Boston Scientific, for helping sponsor this event. First off, we typically do a annual or every other year kind of get together in with Boston Scientific in discussion of spinal cord stimulation, other treatment options. Obviously, with this year, with coronavirus, we've had to take some extra precautions. So I do thank everybody for taking the time and registering and being able to participate with us and being safe. And hopefully we'll be able to learn something and take away something. And whether it's with me or with another pain specialist, just to take away something from today. All right, so today we're basically going to be talking about chronic pain and different types of treatment options. Spinal cord stimulation is a treatment option. There are multiple other types of treatment options as well. But we're basically going to be talking about different things that may or may not help your pain. And how to approach it with your physician. So first things first, anytime I meet a patient for the first time, we're trying to figure out what type of pain is it? Where is the pain coming from? Is it leg pain coming from the back? Is it leg pain coming from the knees? Is this something acute or chronic? Is this something that requires surgery today? Is this something that has been going on for 10 years, going on for 10 weeks? So really kind of teasing out where the pain is coming from, what kind of symptoms are related to the pain. For example, numbness, pins and needles, weakness. And when we talk about weakness, we're usually talking about focal weakness, which means you can't lift your arm or you can't lift your leg. Different types of neurologic signs. Again, just kind of looking for red flags and seeing if it's something that can be treated with injections or therapy, or doesn't need surgical intervention. So what does a chronic pain prevent you from doing? And this is a different answer for everybody. For some people, they just want to be able to stand at the kitchen and make a sandwich. For some people, they want to go play with their kids. For some people, they want to be able to run a 5K. So, chronic pain is interpreted differently with everyone. And the goals, assuming that we can reduce the chronic pain, is different for everyone. So this is just a very simple diagram of just kind of different things that we're hoping to achieve by reducing your chronic pain. So being able to do simple things around the house, workplace, being able to work. Obviously, with right now, a lot of people are working from home, so just being able to sit at the computer for 8 hours a day, that can cause pain as well. So there's different goals for different people. Playing with their kids or family, playing outside or doing things that they like to do, and gardening, things of that nature. A common question is sexual activity. So basically we're trying to reduce the pain so you can go back to your normal life. And spinal cord stimulation is a great treatment option for that. So different types of therapies, and these are some of the more common things that you may or may not have tried. NSAIDs, which are non-steroidal anti-inflammatory drugs, such as Motrin or Aleve. There's obviously different types of medications as well, such as Flexeril and other types of antidepressant medications. So there's many types of medications that may help out with pain. Physical therapy, dry needling as well. TENS unit, which is, or TENS, which stands for transcutaneous electrical nerve stimulation, is basically a therapy device that can be done with a physical therapist, or you can do it at home, where they basically place small electrodes on your low back, on your hips, on your knees, wherever the pain is. And actually, this is important in regards to spinal cord stimulation. There's a lot of overlap with it. So very briefly, a TENS unit, the theory behind it is something called gay theory, where you have sharp receptors and dull receptors, and when we talk about pain. So the TENS unit basically provides a vibratory sensation, and which activates the dull receptors and theoretically turns down the sharp receptors. Spinal cord stimulation is very similar to that. We'll get into that. Opioid treatments such as Percocet, Vicodin, fentanyl patches. As everyone is well aware, the opiate epidemic, or the opiate crisis, which is kind of overshadowed right now with another epidemic. But with the opioid crisis, the more acknowledgements, with the president, with state regulations, with federal regulations, which is all good things. Opioids definitely have a role. Post-operative pain, palliative care, or cancer-related pain. That is definitely what opioids were intended for. But it quickly became rampant with any type of back pain or any type of knee pain. And that's what we're trying to do here. We're basically trying to provide, or at least discuss about different options that are not necessarily just taking a pill. Drug pumps, a little bit of a a dying type of treatment, but still is out there. Drug pumps essentially are a reservoir of medication that is connected to your spine, and it delivers a small dose of could be morphine or could be some sort of muscle relaxant, things like that. But basically, it's a reservoir of medication that is continuously pumped into the spine. Again, typically is for more palliative care, things of that nature, but it is done for back pain, things like that. Surgical intervention, everybody knows about spine surgery. Some people may have, fantastic stories about it, but unfortunately, it doesn't always work. Unfortunately, not everything always works. But again, there's definitely a role for it, and there's definitely a need for it with the right circumstances. Nerve blocks, such as joint injections, epidural steroid injections, facet blocks, knee injections, shoulder injections. There's a plethora of different types of injections out there for different types of pain. Again, we're going to go into that a little bit more as well. So, two options that may not have been discussed with your pain physician are radiofrequency ablation and spinal cord stimulation. So radiofrequency ablation is a procedure that's done for typically low back pain, neck pain, not so much the sciatica type pain that people describe, shooting down the legs. We're talking more chronic low back pain that stays in the back or buttocks, or chronic neck pain that stays in the neck or maybe into the shoulders. Spinal cord stimulation, again, we're going to go into that a little bit more here in a second. So just going back into radiofrequency ablation, essentially what it is a very focused burn at the sensory aspects of the joints. Like I said, it's more commonly done for backs and necks. It is done for knees and hips as well. The intent of it is to decrease the sensory aspect of the pain. So, for example, low back pain. You're basically trying to burn. Can I point on here? Let's see. Yeah, I can.
Yeah. Mm-hmm.
So this is not a great picture, but basically a probe. It's essentially a Teflon coated needle, and at the tip of the needle is where the burn actually happens, where the radiofrequency ablation actually happens. So essentially what we're doing is using a needle and getting it down to specific nerves called medial branches in the back, and basically tapping into them and creating a very small burn. And essentially the radiofrequency heats up the tissue and causes the lesion or the burn. When we do the procedure, there's a lot more to it, but we essentially numb up the area before you do the burn. So you don't necessarily feel the burn, but you feel more of a deep ache or deep pressure. And each burn is typically 90 seconds. This can be repeated down the road if needed. Radiofrequency ablation, the textbook answer is 12 to 18 months benefit. Nerves do regenerate, but very, very slowly. They don't nearly regenerate as quickly as your skin or other types of tissue, but it can be repeated if needed. A lot of times a single RFA or a single burn actually does the trick for several years, actually. All right, so spinal cord stimulation is just a kind of a gross overview of different aspects of it. Essentially, I describe to patients, think of it as a pacemaker for pain. It's basically a generator, a small generator or small battery that's hooked up to leads, and those leads go to a specific tissue or specific location. So for a pacemaker, the leads go to a specific part of the heart that allow it to beat regularly or to stimulate certain tissue or conductivity. We're basically putting this into what's called the epidural space that abuts the spinal cord on the sensory aspect and stimulating the nerves there that distracts the pain or masks the pain. So who can benefit from spinal cord stimulation? A lot of people can benefit from it. The typical patient that I see that is thinking about it is usually for low back pain, leg pain. It's typically someone who has had a prior surgery, and usually a laminectomy or fusion, and either A, doesn't want another surgery, or B, can't handle another surgery because of health conditions, COPD or other things, or C, they just, just can't fathom undergoing a third fusion or fourth fusion, things of that nature. It can be done for people that have had no back surgery as well, as long as certain criteria are met. The criteria are neuropathic pain, which basically means nerve pain in the back or down the legs. Failed back syndrome is kind of what I was getting towards, basically someone who's had prior back surgery and still with back or leg pain. Chronic pain, by definition, needs to be more than 6 months. I would say certainly most of my patients that I see, when we consider this, it's usually more years, several years before, versus just 6 months. I feel like that's a bit too short. Back pain, leg pain, feet pain. And when we talk about back, we can certainly cover low back pain, buttocks pain, hip pain. And we basically place the leads in different locations based on where the patient's main pain concern is. CRPS, which is complex regional pain syndrome, or RSD, reflexive sympathetic dystrophy, they're essentially the same thing. Essentially what that is the sympathetic nerves are in overdrive. The common story is someone fractured their ankle, and a year later, everything is well healed, but they're still having a lot of pain in their foot or their leg or their knee. There's usually some swelling involved, some discoloration, and essentially what it is your sympathetic nerves are still going in overdrive. Your sympathetics are basically your fight or flight nervous system, and it is still active. So spinal cord stimulation is actually a fantastic treatment for that. Medications. So, the big goal for spinal cord stimulation is to reduce opioid medications or medications in general, and reduce somebody's level of pain. And typically this is, not last line, but getting there. You've already tried the physical therapy, we've tried TENS units or radiofrequency ablation or epidurals or different types of injections, and still not getting great benefit or not getting long-lasting benefit. So a typical patient that I'll see, that we've done epidurals on, let's say they get 100% benefit but only lasts for 2 days, then it's certainly not worth, the rigmarole and the risks of getting an epidural or certain type of injection that's only going to be beneficial for a couple of days. So basically, there's a limit to everything, and so that's, we want to exhaust all the more traditional, the lesser invasive procedures first before we consider spinal cord stimulation. So spinal cord stimulation is also called neuromodulation. It is a FDA-approved device. It has been around for over 40 years. I tell my patients that think of spinal cord stimulation like an iPhone. It's been around for a decade plus, or specifically for the phones. But obviously, every year they just get better and better and better. So same thing with spinal cord stimulation in general. Certainly has gotten better and better and better, especially over the past few years. A lot of advancements in technology, advancements with the battery life and what they can do. MRI compatibility is always a discussion as well. And one of the check mark that says reversible meaning that, let's say you do great with the trial and you do great with the permanent, and somehow, some way it gets infected. The device can come out. It is a surgery to remove the device, but it can come out. Or let's say do great with the trial, do great with the permanent, and a year later, it's for whatever reason isn't working, and you want it to be taken out. It can be removed, and that is different than, let's say, a 3-level fusion, where once the fusion is there, it's pretty much there. It's not going anywhere. So that's what I mean by reversible. Non-drug therapy, it is exactly that. This is not a pharmaceutical device. It is not pumping in any sort of medication or opiates into the spine. It is using the electrodes and basically masking the pain, masking the sensory aspect. The other thing is with spinal cord stimulation, this is not going to make you stronger, weaker, anything like that. This is purely a sensory thing. I do have some patients who it helps their pain, and then therefore they go to the gym, and then they can get stronger that way or do the therapy they need. So you can theoretically become stronger in that regards. But in terms of, will this make my legs jump? Will this make my arms jump? The answer is no, because you're placing the leads on the sensory aspect of the spinal cord. This is covered by most insurances, including Medicare, workers' compensation, or workers' comp. There's certainly some criteria and some hoops to jump through before we can get it approved. So let's say you come into the office and see me tomorrow. We're not going to do it the next day. There's certainly hoops to jump through and to get authorization, but it is something that is approved by insurances. This is not an experimental device or anything like that. So how does this work? So spinal cord stimulation, the best part about it is that you can try it before you buy it, meaning that there's a trial period first that I do in the office, and then if you do well, then you do the permanent placement. The trial is done basically like getting an epidural. So, for example, epidural steroid injection, you achieve epidural space, basically get the needle into the right space, and then you inject a steroid. With this, we're getting the needle in place, but instead of injecting a medication, I'm threading a small wire, kind of the size of a spaghetti noodle, through the needle, and then basically placing the needle or the leads into the right space in the spine. And everybody's pain is different. So the location for where we place the leads can be anywhere between typically T7 to maybe around T10. T7 is right around between your shoulder blades, kind of your scapula, and T10 is just a little bit lower. So usually it's placed around the shoulder blade area. You're not going to feel it, something in the shoulder blades. The reason why we place it that high up is because that's where the sensory fibers for the back and the legs start, what's called the dorsal column. So basically we're trying to catch it where the pain, or I'm sorry, where the nerves originate. So in that case, we can better target different areas of the back or the legs. And then the trial is just that. So it's usually a 3-day up to a 6-day trial. The leads are placed and essentially just taped to your back, and you have a external battery pack with you for that 3 to 6 days. The battery pack is held around your waist, kind of like a fanny pack. And like I said, the leads are in the spine, and then essentially taped to the back. Some people use sutures or things like that to anchor it in place. I do use basically a fancy super glue that kind of holds it in place a little bit better for that trial period. When you come back 3 days or 6 days later, those leads come out, the tape comes off, the battery comes out, everything is removed, regardless of if you got 100% benefit or 0% benefit. It is just a trial. Those leads do not stay there for the long haul. When we talk about the permanent placement, yes, the permanent one is permanent. It is placed with the intention of being in there for several years or even decades. The reason why the trial is done is because we are trying to find out where the pain or where the placement will best cover someone's pain. And based on the location of the trial leads, we then try to mimic it with the permanent placement. So that's the whole reason why the trial is done before the permanent. So how do you know if the spinal cord worked or spinal cord stimulation worked? What we're looking for is at least 50% benefit. I would say majority of my patients, if they know it's going to work, it's usually more than that. It's more than the 80, 90%. It's typically a light switch moment. It's typically a, yes, this is going to do great, or unfortunately, it's not going to work. You know, what were you able to do during that trial period? Were you able to walk more? Were you able to, you know, make a sandwich at the counter, where you weren't able to do that before? Were you able to walk the dog longer? Things of that nature. Were you able to reduce your consumption of opioid medications, Percocet, Vicodin, things like that? Were you able to sleep better? I would say that's a very common thing that I hear is during the trial they've had the best sleep that they've had in years because their pain was just under control and it wasn't waking them up during the night, so they just felt refreshed. I would say that's, you know, these are just basically things that we're looking for to say, hey, is this going to work for you or not? You know, again, not everything works for everybody, but this is the only thing in spine medicine that you can try it. So one of the more recent things with spinal cord stimulation is what's called combo therapy. So with Boston Scientific, we can run what's called paresthesia and non-paresthesia. Paresthesia is the vibratory sensation that you'll feel like a TENS unit, basically like a almost like bubbles. It's usually not a discomforting feeling, but it's just a different feeling, and people describe it differently. But essentially, it's a pressure sensation or vibratory sensation, and just kind of in the area of the pain. So again, using that gate theory, that TENS comparison, where the paresthesia or the vibratory sensation should theoretically decrease the sharp burning sensation that we're trying to get rid of. Paresthesia free, or what's called no feel sensation, is a whole different type of frequency where you don't feel that paresthesia. Some people don't like it. Some people say it bothers them too much. So a paresthesia free or a no feel, you don't feel that vibration. There's a whole lot of science behind it, but essentially what it is, it kind of scrambles the brain, or scrambles the receptors, the transmission that goes to the brain, specifically for your pain, and just wipes it out completely. And you can use both. You can use a combination therapy, so a paresthesia and a non-paresthesia. You can have the opportunity to run different types of programs, and that's what's great. And this is a fairly new innovation in the past couple of years, and definitely been noticing some tremendous benefit with this new innovation, to be able to run both types of therapies at the same time, or being able to choose one versus the other. Some people don't like to feel the sensation at night, so they'll turn it on to no feel at night, and then during the day at work, they might use the paresthesia when they actually can feel it. This is a study from about 3 years ago, essentially just showing the longevity of it. So basically, it's a trial showing that after 2 years, patients that had spinal cord stimulator, placed 2 years ago, their average pain score went from an 8.6 out of 10 to essentially a 3 out of 10. So again, that's, it's not a 0, unfortunately, but it is significantly reduced compared to an 8 or 9. A lot of people, 8 or 9 is getting up there. It's getting to that debilitating state. Versus a 3 is more of a nag. It's something that reminds them that, hey, you have back pain, but it's to the point that you are functional. So again, we're trying to look for a reasonable outcome. Yes, there are definitely people that get tremendous benefit, 0 or a 1 out of 10 pain, but results not typical. You know, not to sound like a commercial, but results not typical. I would say in general, it's more that 70–80% range benefit, which is still pretty good. All right.
All right. Now time to switch gears for a minute. Thank you, Dr. Tseng. That was a wealth of information, and we will take a second to do some question and answers. I've been checking my text and in the chat, and I noticed some good questions coming in. So we'll get to those. But we do want to give Mr. Brown a chance to share his story. Let me unmute him here. All right. We can turn your screen on too. Can you hear me, Mr. Brown?
I can hear you very well.
Okay, I can hear you good too. You can take it away.
Afternoon, everyone. I guess the big thing to start with is, what is my pain story? I spent 22 years as a Army Ranger and a chopper pilot. I've been shot down 3 times, multiple lower back and neck injuries resulting from that. In about 1993, I was on a steady dose of opioids, went through those up through until I got the spinal cord stimulator. Went through the gamut of everything from the physical therapy to the nerve blocks. I would get some relief, temporary, but not anything substantial. And of course, as Dr. Tseng alluded to earlier, opioids, there are some very bad side effects that result from the steady use of those. I approached Dr. Tseng, and we did the temporary or the trial period. Within 24 hours, I saw a significant reduction. I would say in the neighborhood of 60 to 70% reduction in the pain that I was experiencing through my lower back and radiating down my left leg. I was actually able to reduce my intake of both the Percocet and the Tramadol on top of the morphine that I was taking at the time. So with that success, it was within 30 days, I was scheduled for the permanent placement of the spinal cord stimulator. Procedure went flawlessly from what I could tell. Obviously, I was not awake for the exact procedure, but I woke up, things were going well, went home that same afternoon or evening, and immediately felt much better. As the medications wore off from the surgery, I could tell that the stimulation was working, played with the remote control, working with it to find out which sensations, which locations worked the best. I believe I had at that time about 11 different programs, worked with them all, found those that more importantly helped me with my sleep, particularly the no feel sensations. They were just phenomenal. I actually slept through the night within 24 to 48 hours after having the permanent in. No real discomfort from the incisions, both the battery incision and the upper incision where they inserted the electrodes. There was no irritation, no inflammation of any great amount, not even any itching, to be honest with you. As far as my life, I was no longer a couch potato. I wasn't a drugged out individual just sitting there taking up space. I actually began to do more and more things, got out more, exercised more, and was actually able to get back into motorcycle riding. It was, like I said, a game changer. It was outstanding. If I were to recommend anything to anybody who's even thinking about this, do the trial. If the trial gives you any relief at all, and you're going to know almost immediately about it, do the trial. If it works, I would encourage you to really research into doing the permanent installation of the system.
All right. Thank you so much, Mr. Brown. And what state are you in right now, enjoying your pain-free living on your RV?
Well, we're in our new home of South Dakota. We're in the Black Hills here.
That's awesome.
Yeah, we've picked up a small ranch, so I'm going to get back into cattle and horses.
Good for you.
Yeah.
Good for you. That's awesome. We appreciate it. It's always nice for patients to hear from a real actual patient, one that's just volunteering their time. So we appreciate it. While I've still got you on here, Mr. Brown, I did have one question. A couple patients have been texting and sending questions. One thing that was asked is, how easy is it to charge your battery? Or what does that look like? That's something that patients want to know. Do you mind covering that real quick?
No, not a problem. When the battery starts to get low, it's a simple procedure with the charger. They provide you a belt that you can Velcro around your waist. I've charged my battery while driving, while riding my motorcycle, while riding a horse. You just strap it on, and depending on the level that I allowed the battery to go down, typically within an hour or an hour and a half, I'm fully charged again.
Yeah.
And I found I can get anywhere from 7 to maybe 14 days on one charge, depending on the level that I set my stimulator at.
That's awesome. Yep. And just like you said, your remote kind of tells you exactly when you need to charge and things like that. Yep.
Exactly. And believe it or not, you can physically feel if you let the battery get too low. I can take that sensation and say, check my remote. Yep, I need to charge.
Ah, I learned something new today. Yes. Well, thank you again for your time. We have some more questions coming in. Let's see, this one, Dr. Tseng, this one would be a good one for you. Will spinal cord stimulation allow me to be free from pain medication? And I know Mr. Brown talked a little bit about this.
Right. So obviously that's certainly a goal. That's something you have to talk with your pain physician day one, what your goals are. And realistic goals versus not realistic goals. So realistically, yes, you can reduce your pain medication, assuming that everything goes well. Obviously, with pain, there can be a psychological aspect or an addiction aspect of it as well. So yes, theoretically, you can decrease your pain medication. It may be very simple. It may be once we knock out the pain that we can knock out the meds. But typically, it's going to be a little bit more complicated than that. And, basically a stepwise approach to how to reduce the medication, signs of withdrawal, things of that nature, depending on what type of medication you take. So theoretically, yes, and that's definitely the goal of it. And I would say a lot of my patients, just like Mr. Brown said, were able to reduce their medications. May not be completely down to zero. Obviously, again, that's the goal. But if we can reduce it significantly to the point that your body and your mind doesn't depend on it 24/7.
Yep. Yeah. Any treatments geared, anything that you talked about, Dr. Tseng, not just spinal cord stimulation, but any treatments geared towards the neck pain, or cervical treatments?
So spinal cord stimulation, you said not just spinal cord stimulation, but let's start with spinal cord stimulation. So yes, you can use it for neck and arm pain, even headaches to a degree. There's certainly some limitations with spinal cord stimulation with neck and head pain. I will say it's a little bit more tricky, and it's not because of a limitation based on the device. It's just the way that our spine is wired. You just can't get the leads all the way up to where the neck pain would start. But you can use it with great benefit with arm and hand pain. But then your question about treatments for neck pain, yes, as we discussed earlier, epidural injections, RFA, radiofrequency ablation, joint injections, things of that nature can definitely help with different types of neck pain. But coming back to one of the first slides is just finding out, making sure that you have the right diagnosis. Neck pain can be from the neck, it could be from the brain, it could be other issues as well. It could be a visual thing that's causing headaches. So there can be many different factors.
Another good question. If you get the permanent implant, now we're talking back about spinal cord stimulation, what is the recovery time for the permanent implant?
So the permanent implant is a surgery. It is done either at an outpatient ambulatory surgery center or at the main OR. But it is a surgery. It is not something that's done in the office. The recovery time theoretically should be about a week. Basically, what we're waiting for is the skin to heal up, for the tissue to heal up. With spinal cord stimulation, you're not waiting for the bones to fuse. This is not a fusion where it could be 6 to 12 months of healing time. This is the leads are placed, and if everything goes well, assuming that the patient is relatively healthy, should start, the healing process fairly quickly, and the skin should heal up fairly quickly. So if in an ideal world, if everything goes well, about a week.
And most of the surgeons will see the patients in 2 weeks for a 2-week post-op checkup, and that's where they'll check on all those things too. And one of us from Boston Scientific, myself or one of my 4 other teammates, will be at that appointment to go over everything with you, get the programming adjusted if need be. Let's see, so many good questions, but looking out for time, how long does the battery last? And does it need to be replaced? I'll answer this one. Our newest battery, the latest and greatest battery, Dr. Tseng talked about it doing multiple frequencies at the same time, the paresthesia and non-paresthesia. That is warranted for 5 years. Our data shows, and most of our patients get about 7 to 10 years out of that battery before it needs to be changed. Just like a cell phone or a laptop, it does have a limited life before it dies. However, that surgery to get a new battery is much more simple than getting the whole implant put in. We call it a battery swap. That's exactly what it is. You are back with the surgeon, you're under anesthesia, outpatient, but it's about 10 minutes, and I'm not exaggerating. It's so quick that the minute you're under anesthesia, you're almost coming back out. And that's simply so that the surgeon can just replace that battery that's right under the skin. So that's something to think about. It does need to be replaced. Let's see. A big question that I'm getting here is, can I go through TSA or through the airport with my stimulator? I'll let you take that. I know you hear this question a lot, Dr. Tseng.
Yes, you can. Obviously, there's precautions or just one more step. Just like someone who has a total hip replacement or shoulder replacement, any sort of foreign device, pacemaker, like I said, you get a card from Boston Scientific or whomever is the device company, and you essentially get wanded down, and that's that. And like I said, it can be same thing as if you had any other implanted device. You get the same thing. You get the card. You let the TSA member know that, hey, I have this device in me, and then they wand you down.
Yep, that's exactly right. Another good question. I actually hear this a lot, and this will be the last one we take just to honor everybody's time. Can I go swimming with the implant? So yes, once it's all implanted under the skin and you're healed, which could take that 2 to 4 weeks depending on how your incisions are healing, yes, you're free to go swimming. You don't have those restrictions like you did in the trial where you had the tape and all of that, like Dr. Tseng was talking about, where you can't shower and you can't get that wet. Once it's implanted and healed, you can swim. I'm sure Mr. Brown could tell you he's riding motorcycles. So yeah, and horses. So thank you, everybody. If I did not get to your question, I've got lots of texts, lots of emails. I'll be following up, me and my teammates, with everyone. You can see this screen. If you have specific questions, not only about spinal cord stimulation, but about many of the different things Dr. Tseng spoke about tonight, I would encourage you to make an appointment with him. His office phone number is right there, and I'll read it for those that can't see the screen: 757-547-5145. Just ask to get an appointment. He will figure out where you are on that continuum and the best treatment plan for you. If you want to learn more specifically about Boston Scientific and spinal cord stimulation, you can see our website, controlyourpain.com. It's pictured there in the blue bar. It's a wealth of information specifically about spinal cord stimulation, and you can also see all the different physicians that do the procedure. Of course, Dr. Tseng is doing it here in Chesapeake. Again, thank you for jumping on. I'm happy to answer any other questions. Feel free to text me, email me. If I cannot answer it, I will route it to Dr. Tseng and his teammates, and they will get back to you. Thank you for your time.
Thank you very much.
Thanks, Mr. Brown and Dr. Tseng. Everybody have a safe evening.